So far, we've been talking about the coagulation pathways, which is known as secondary hemostasis. Now let's turn our attention to primary hemostasis, which has 4 steps, starting with vessel injury, then proceeding with platelet adhesion, activation, and aggregation. So here we have the endothelial lining of a blood vessel, and some small damage is done to this blood vessel. We're going to zoom into this area and watch primary hemostasis in action. The first step is the adhesion of platelets. This begins with the exposed collagen, as we can see here, and von Willebrand factor floating in the bloodstream, binding to this collagen. As a quick side note, what is one other important function of von Willebrand factor as it floats in the bloodstream? That would be the protection of inactivated factor VIII from degradation, which is not shown in this animation. Platelets then bind von Willebrand factor via the GP1B receptor. This completes our platelet adhesion. This binding causes platelets to release ADP and calcium, which are both necessary for coagulation. We spoke about calcium's important role in secondary hemostasis earlier, and now we see that ADP goes on to activate other platelets in our activation phase. This helps our platelets adhere to endothelium by inducing the expression of the GP2B3A receptor, which you'll remember from our previous lecture binds fibrinogen that later converts to fibrin and allows the platelets to aggregate with one another. Now all of our activated platelets that are expressing the GP2B3A receptor are ready to cross-link with one another and the fibrin mesh network to form our clot. There are 2 opposing forces now at work: the pro-clotting force, and what would be second? Well, this may come as no surprise, but second would be the anti-clotting force. The pro-aggregation force is generated by platelets releasing thromboxane A2, which slows down the blood by vasoconstriction and increases platelet aggregation. Opposing the aggregation forces are the endothelial cells downstream that release prostaglandin I2 and nitrous oxide, which not only increase blood flow by vasodilation to try and flush out the clot, but also directly decrease platelet aggregation. The goal isn't for one of these 2 forces to win, but rather to allow for a finely modulated balance that gives the opportunity for an appropriately sized clot to form and repair the damage. Not too big, but not too small. What substances bind each of the following platelet receptors? ADP receptor, GP1B receptor, and GP2B3A receptor. That would be ADP for the ADP receptor, GP1B, von Willebrand factor, and GP2B3A bind fibrinogen, which later converts to fibrin. Now we just discussed thrombogenesis, or the formation of an insoluble fibrin mesh network, in some depth, but let's add a little extra detail, especially concerning the pharmacology that we'll see later. We just went through the steps of injury, adhesion, activation, and aggregation, but to summarize, once von Willebrand factor has bound the exposed collagen of the injured blood vessel, von Willebrand factor binds the platelet by the GP1B receptor and induces the platelet to release ADP, which then binds the ADP receptors of other platelets. These other platelets will now express the GP2B3A receptors. These receptors enable the linking of platelets with fibrinogen, forming a strong platelet and fibrin clot. Inside the platelet, you can see the use of cyclooxygenase, or the COX enzyme, to generate thromboxane A2 from arachidonic acid. In contrast, inside of the endothelial cells, you will see von Willebrand factor, thromboplastin, TPA, nitrous oxide, and prostaglandin I2, which are mostly anti-aggregation factors of platelets as long as the endothelial cells remain intact. As a preview to the pathology and pharm sections, there are some conditions that develop when particular steps in thrombogenesis are dysfunctional, or drugs are given that block different steps of this pathway. Bernard-Soulier syndrome is a deficiency of the GP1B receptor. And what would this effectively do? Well, it would prevent platelet adhesion to von Willebrand factor, and thus do a great job of preventing adhesion, activation, and aggregation of platelets. Similar to Bernard-Soulier syndrome, platelet adhesion is inhibited in von Willebrand disease, but this time it's due to a deficiency in von Willebrand factor. The boards love to ask analogy questions almost as much as the SATs do, and this is a pretty good one. The mechanism of Bernard-Soulier syndrome is similar to what other disease? That would be von Willebrand disease. Ristocetin induces the binding of von Willebrand factor to GP1B. Ristocetin is used to test for von Willebrand disease. This test is called an agglutination test. A negative agglutination test would mean that when ristocetin was administered to drawn blood, there was no agglutination found, and therefore there was no von Willebrand factor available to act on the GP1B receptor. This agglutination test would also be negative if there was no GP1B receptor available for von Willebrand factor to act on, again reminding us of the parallels between von Willebrand disease and Bernard-Soulier syndrome. Ticlopidine, prasugrel, and clopidogrel block the ADP receptor and thus block the subsequent GP2B3A expression. Abiciximab is a monoclonal antibody that inhibits the GP2B3A receptor directly, while Glanzmann's thrombasthenia is a deficiency of the GP2B3A receptor itself. Here again is another great analogy question, and I would say that test writers find abiciximab and Glanzmann's more testable than our previous analogy. Similar drugs to abiciximab that are not antibodies are eptifibatide and tirofiban. Both of these inhibit GP2B3A directly. As we've discussed before, aspirin inhibits cyclooxygenase and subsequently thromboxane A2 synthesis, and it bears repeating as it is such an important test topic regarding the inhibition of thrombogenesis. All of these conditions inhibit platelet plug formation and increase bleeding time. This information is high yield for the boards, and I would suggest finding a method that works for you to remember the information covered in this section. Now let's test ourselves with a USMLE style question. A 60-year-old man with a history of multiple myeloma is 40 days status post allogenic stem cell transplant. Due to graft versus host disease, he has been hospitalized and on levofloxacin since his transplant. During an intravenous exchange, his nurse notes that his venous access site is oozing blood. Laboratory tests reveal a prolonged prothrombin time, a prolonged partial thromboplastin time, and a normal platelet count. A deficiency of which of the following coagulation factors is the most likely cause of the patient's abnormal laboratory tests? Factor 2, Factor 5, Factor 7, Factor 8, Factor 11, or Factor 12? The answer here would be Factor 2. Here we can see that our patient is on long-term broad-spectrum antibiotic therapy. This type of therapy can induce a vitamin K deficiency by clearing the intestinal flora that we are dependent upon for vitamin K synthesis. As we discussed earlier, vitamin K is required for the functioning of clotting factors 2, 7, 9, and 10, as well as proteins C and S. So immediately we are limited to factors 2 and 7 in our answer choices. Factor 7 is involved in the extrinsic pathway and is measured by prothrombin time. However, this would not affect the PTT as we see in our question stem. Factor 2, or prothrombin, on the other hand, requires vitamin K and is involved in the common pathway. Therefore, Factor 2 affects both the intrinsic and extrinsic pathways and results in prolongation of both prothrombin time and partial thromboplastin time. Well, that's going to cover hematology and oncology physiology. We'll be moving on to pathology in the next video. See you then.